Without further delay, I would like to introduce our esteemed speaker of today's webinar, Professor Dr. Yasmin Abdul Malik. Professor Dr. Yasmin Abdul Malik is a visiting clinical consultant and a part-time lecturer at the Medical Microbiology Department, Universiti Malaya Medical Center. She obtained her MBS from the University of Malaya in 1982, MSc in Medical Microbiology from the University of London in 1986, and was admitted to the Royal College of Pathologists in Virology in the UK in 1992. She was conferred a Fellow of the Royal College of Pathologists UK in the year 2000. Prof. Yasmin has over 30 years of experience in diagnostic research and has published over 100 journal articles and guidelines. She has been invited as part of the expert panel and given recommendations in updating the national HBV as well as HCV testing algorithm. She also has given numerous talks on viral hepatitis diagnostic issues nationally, regionally, and internationally. And now I would like to invite Prof. Yasmin to deliver her talk. Prof. Yasmin, the floor is yours.
Now, I've been invited to talk about these updates, so I'll go right through the straight away with regards to the updates. Next slide. Next slide. All right. So I'll begin first by talking about well, essentially hepatitis B. All right. This is just a nice little graph to remind you. But when all the markers of hepatitis B, which is a lot, will appear, but note two additional flares. One that relates to hepatitis B, where you have reactivation, and hepatitis B flare, which I will also talk about, and what we will need to do to address that. Next slide. Right. Now we begin first by a very updated recommendation by CDC in March this year. Right. As you can see, this new recommendation relates to universal hepatitis B screening. For many years, including Malaysia, what we have been essentially doing is basically doing HBS and anti-HBS. All right. Now, as of March this year, in relation to what has been happening, especially for the past 5 years or so, CDC have basically updated by saying that now Hep B screening to be done once during a lifetime for those aged 18 and above. That's new. But what's important is the second one. But how now the screening test will include HBS antigen, anti-HBS, and total core antibody. In other words, what we call a triple panel. Now, the rationale for this, all right, bearing in mind that we have these three tests available, but we've been using the first two all this while, but rather apprehensive when it comes to, hepatitis core antibody. So, hold on, let me. The rationale basically being is that they include this because, for one thing, we know that it allows us to detect an active infection, so can link that person to care. And the other one is actually it helps resolve the problem of those who are immunosuppressed. All right, because if you have those three, then you can look at those who are susceptible to reactivation. Okay, and of course, these three will help us determine whether the person is susceptible, need vaccination, and of course whether they are vaccinated. But the main issue is the first two. And the other thing that's rather interesting is that you don't have to use the same three tests all the while. Once they have got these three panel screening, any future test basically will be done appropriately. In other words, if the person have not been vaccinated, then you just use HBS antigen and anti-HBC. Note, not anti-HBS, all right? Because the person have not been vaccinated. So you'll only look for those two markers. But the initial starting is those three, all right? Next slide. Next slide, please. All right. The other one is to do with screening of pregnant women. Now, this actually is not new. This is basically already highlighted and recommended by ACIP in 2018 in that Hep B screening, all right, to be done during each pregnancy, preferably in the first semester, irregardless of whether the person is vaccinated or not, whether the person has any history of testing. In 2018, that's ACIP's recommendation. And of course, what's added is that the pregnant woman with history of that triple panel screening and without subsequent exposure, all right, to Hep B, in other words, no news exposure, all right, will only need just HBS antigen. That's it, all right, because the triple panel screening has been done, so they just need just HBS antigen. Next. And there's this group called risk-based testing. Now, basically, you're talking about testing all those with increased risk, all right, of infection. I'm sorry for those who have raised their hands and all that. I will try to answer them towards the end because I have got over 40 slides to go through, and it's already 2:30. So I hope UITM will allow time, all right, for me to answer all these questions at the end for everyone, all right? So you're welcome to raise your hands and I'll try and answer them along the way, but please allow me to finish my slides, all right? Now, again, with regards to risk-based testing, testing of all those with any history of increased risk, doesn't matter how old they are, if they may have been susceptible during that period of increased risk, right? The other thing they suggest is periodic testing. These are only meant for those susceptible. Doesn't matter how old they are, but as long as they have got ongoing risk of exposure, all right, and that risk of exposure can persist, this suggests that periodic testing. Now, who do you mean susceptible people? Anyone who have never been infected with Hep B. In other words, those who have been total anti-HBC negative, all right, or and not only that, but did not complete their vaccination or are have been vaccinated but are non-responders. Right? So you do that. That's what they are suggesting: periodic testing for this group. Next. Next. All right. Now, the issue about why, especially in Malaysia, we're reluctant to do co-antibody is what do we do? All right. Next, when we do have this results, which basically says, all right, if you have HB, look at the screening that involves those three markers. If the person is HBs antigen positive and co-antibody positive, then okay, we see evidence of chronic hepatitis B. If it's more than 6 months, would you want to vaccinate? No, but you may need additional testing or management if required. All right. Now, if the person has anti-HBs and anti-HBC, definitely we can say is past infection having been resolved. No problem, no further management needed, except if they are immunocompromised, all right? But the issue is more to do with if they're only core positive. Excuse me, we had problems of that for many, many years, mainly because we can tell that, yeah, maybe the person has been exposed to Hep B before, but, all right, it could be a false positive. And the issue could be the person could be immunosuppressed, and therefore the requirement of HBV DNA is important, right? So, would you want to do this everywhere? No. In areas whereby the area in terms of endemicity is either intermediate or high, right? So, would you want to do this in Malaysia? You need to basically discuss with the pathologist, gastroenterologist. Now, of course, if you just anti-HBs positive, that's it, no problem. You're deep immune and no further testing required. Next slide. Oops. Now the reason, the thing I want to raise is the problem of isolated, all right, anti-HBC, because we find that, all right, in the population of intermediate or high risk. It's found commonly due to previous exposure to Hep B. Majority would have recovered from the acute infection early in life, and the anti-HBs, ironically, have waned to undetectable levels. You need to understand, our test kits and all that have got a limit of detection. So if the antibody, anti-HBs have actually gone down to almost undetectable level, then the only thing left is the core antibody, even though they have been exposed and recovered very early on. So the core antibody will persist for life, but the anti-HBs, right, have been known to actually come down to undetectable levels. In other words, it's there. It's just that our test kit is not able to detect it. All right. And of course, for those who've been chronically infected for decades, even after clearing the HBs antigen, somehow or other, I've seen cases, even when I was in UKM, of patients, they have been HBs antigen negative for a long, long time. All right, waiting, and then they've recovered very well. Core antibodies there, but they just don't seroconvert. All right. Again, is it because not there? No, it's just because our test kit's not able to detect the low antibody. The thing I need to highlight is the bulk of my presentation is actually via the American Association for the Study of Liver Disease guidance 2018. This guidance, I strongly recommended it because it's a multi-page guidance which has got a huge section on diagnostics. Of course, it's got a lot on management and prevention and stuff. But the thing I love is the fact a lot on diagnostics. In fact, this paper has been cited over 3,000 times. All right. Now, it has appeared in over 3,000 articles. That's how fantastic this paper is. People are still referring to it. And ironically, the AASL, they have yet to update the Hep B one. They currently have updated the Hep C one. They have kept this. All right. So this is a very good article, which I strongly recommend for you to look at, not just in terms of diagnostics, but also in terms of management. People have been using CDC, WHO, have all have been referring to it, and so am I. All right. And now the other thing that's beautiful is number 2. Now, in the early days, I remember very, very early days, blood bank was very reluctant to do anti-HBC because they become positives. All right. Not because the patient is positive, because that patient, they couldn't donate, they couldn't use that blood, they donated blood. Ironically, is that back then was high, significant level of false positivity. Of course, now it's less common. All right, with the more specific tests that's available, false positive anti-HBC is less common. All right. In fact, we don't see it in low prevalence areas as long as they have got no risk for Hep B infection. The other thing you need to remember is that it may be the only marker of Hep B during that window period of acute hepatitis B. So in other words, these people, of course, you have to look for the IgM, all right, the core IgM. Must never forget, after all these years of more, almost 30 years of that, the issue of mutations is now very common. So you need to understand, HBs mutations will lead you to false negative HBs antigen result. In other words, you're looking for HBs antigen, yeah, but the test you're using is not detecting core mutations. So all you're picking up is just anti-HBC. All right. These are the issues which you need to be well aware of. We may need to resolve as and when we see this patient. Next slide. All right. So for the in terms of its use in blood banks, whether blood or organ donors, all right. Like I said, in terms of its specificity, great, 99%. All right. For blood donors, for those with non-Hep B medical conditions, the specificity is still pretty good, 96%. So yeah, routinely perform, great to do. But the thing is that you need to repeat the anti-HBC over time. All right, because what you find subsequently is that if by chance they do become negative, then you know it's a sad way of determining it. That means the initial anti-HBC was a false positive. All right. So when considering the benefit of using an anti-HBC positive donor organ with possible, remember, mutation, with possible occult Hep B infection, then you got to weigh the pros and cons. All right. In other words, what's more important? Is that possible transmission or is the clinical condition of the recipient patient? All right. Next slide. Next. Now, of course, the issue, all right, is that previously Hep B infected patients recovered new immunocompromised patients or those who are about to begin Hep C therapy, they are at risk of reactivation. All right. And therefore, you need to screen for anti-HBC. Now, if they are anti-HBC positive, then you have to do core IgM to detect, to make sure whether it's a current infection or not. Then you want to do anti-HBe to find out whether it's resolving or not. All right. And obviously, the availability of HBV DNA is very helpful because when it's positive, the person is effective, right? If it's negative, that means, remember, test kits, low undetectable HBV DNA, not because it's truly negative. That's why when we use any kind of test kits, especially when you do PCR work, you need to find out what is its level of detection. All right, the limit of detection varies between different companies. All right, so be careful. Do not do any kind of comparative analysis between two test kits, all right, or two companies, because they have different limits of detection. So ideally, if you use one company, I would suggest you to maintain that, all right, to allow for you to see a trend. All right, it's very difficult to have a trend when you're using two machines with two different limits of detection. All right, so the use of HBV DNA PCR work does involve some discrepancy. Be careful. All right, you may get some outliers if you're not careful. Next slide. No, so what would you counsel? Well, basically, as far as core antibody is concerned, not routinely recommended unless, remember, because immunosuppressed, so HIV infected, undergoing Hep C therapy, or about to start any kind of immunosuppressive treatment. If HBs negative, all right, as well, HBs antigen negative as well, in other words, core antibody negative and HBs antigen negative, that means they are the ones who are not at risk of hepatitis B transmission, whether it's sexually or close personal contact. All right. If one is from a low endemicity area with no risk factor for Hep B, then of course you give the full Hep B vaccine. All right. And of course, no evidence of any high risk behavior. Of course, you don't give the vaccine. Next. Right. Just like. Okay. Now, I'm going to highlight four selected tests because this relates to management of chronic hepatitis. Because once you do that 3-panel screening and all that, know whether or not the person infected or not, so you're going to start on managing chronic hepatitis B. Now, what I've done is selected four tests, which again, AASLD have basically suggested that you want to consider, but they also have they provide their guidelines. In other words, on how you want to address it. The first one, next slide, please. The first one is HBV DNA quantitation. Of course, this one we've been using umpteen times for more than 10 years. All right. The most beautiful thing is that currently the assay has reached such a level that it can detect as low as 5 IU per mil. That is very sensitive. All right, ultra sensitive, in fact. At the same time, it has one hell of a dynamic range, and great levels. In other words, up to 7 log 10 IU per mil. So you can go as low as 5 and can go as high as 7 log. So very dynamic. All right, that's what most of the real-time PCR assays that's available, which is great. All right, but unfortunately, we need to be well aware. All right, that some have got very wide fluctuating DNA levels. All right, some as in patients. Right, varying from undetectable to 2 million. All right, so serial monitoring is vital. All right, it's more important than just one single one-off cutoff value, especially when you want to determine prognosis and the need for treatment. Now, this 20,000, all right, has been used as a cut-off arbitrary value. Actually, it reflects detection limit of historical non-PCR assays, right? So that 20,000, you want to use it, great. If you don't, the so-called single cut-off, fine, all right? But bear in mind, serial monitoring is more important. So you need to be well aware that when you have requests coming in on a regular basis, that's a good reason why they do that. Maybe it's because the patient's HBV DNA level has been going all wonky, so they need serial monitoring. If you want to do a cutoff, an example, all right, this is historical, all right, in that for somebody who is inactive chronic hepatitis B, then the levels will be less than 2,000. For immune active chronic hepatitis B, then the level is more than 20,000. But bearing in mind, for some patients can go more than that. So AASLD basically says, this cutoff thing is more historical than actually recommended, right? Next slide. So in other words, the same thing to bear in mind, because we're used to doing E and NTE testing, all right? So for obvious reasons, all right, if somebody who is E antigen positive, obviously HBV DNA will be high, as opposed to somebody who's E antigen negative. That's logical, all right? And at the same time, of course, the issue is that you're going to get a level of less than 20, all right? Remember, the 20 is the cutoff. In patients who've got chronic hepatitis, a patient who's cirrhotic, a patient who's got hepatocellular carcinoma. So historically, the 20,000 cutoff, as far as AASLD is concerned, is something you need to be well aware of. Okay, something you may want to reconsider using that cutoff, because they have seen patients who've got much higher levels, much lower levels, and yet they've got chronic hepatitis, cirrhosis, and liver cancer, even though the HBV DNA level is low, all right, deemed inactive, yet you can see that. So when making treatment decisions, of course, you need to interpret the HBV DNA levels in relation to the age, how long they've had infection. ALT elevation is vital and continue to be very important, of course, the stage of disease. So what is the AASLD's guidance? Basically, they say it is essential to guide treatment decisions, including when to start treatment and how used to evaluate response to the treatment. All right. So use for that, and not to be used to confirm diagnosis. No, this is more for treatment. All right. Next. The other one is rather interesting. It's about cccDNA. Next slide, please. All right. Covalently closed circular DNA. This has been a rather pain in the you-know-where for almost 10 years. All right. So what is this cccDNA? Basically, now we know the hepatitis B has got a partially double-stranded DNA. All right. Now, this partially double-stranded DNA is actually very relaxed. So it's actually, now they call it a partially double-strand relaxed circular DNA, rcDNA. All right. This is the one that infects the hepatocytes. Now, once this is repaired by the cell enzyme on infection, what it does is it will generate a double-stranded episomal DNA, which is covalently closed circular. Right? This is our cccDNA. Now, the ironic thing is that when it's associated with certain proteins, histone, non-histone proteins, this cccDNA actually forms a very stable mini chromosome inside the nuclei. And it is this cccDNA that actually serves as a transcript template for all the viral transcripts. This is the pain in the you-know-where. Next slide. Next slide, please. All right. So what is its impact? Why are people very hyper about it? Well, basically, the therapies, the Hep B therapies that we have currently, yes, it does slow down the disease progression. However, it's been found it's not curative. That means that's where you get your reactivation, that's where you get flare despite treatment. Why? Because of the inability to eliminate, or better yet, permanently silence this HBV cccDNA. In other words, you have got the nucleotide analogs, you've got the PET interferon, right? Unfortunately, those strategies are not curative because they do not primarily target the HBV cccDNA. In other words, this DNA actually remains in the infected hepatocyte and ironically contribute to the rebound phenomena after stopping treatment. Now, while this cccDNA cannot self-replicate, its levels can actually be replenished either through reinfection or secondary infection. And sometimes, all right, it rarely happens, but you get intracellular recycling of newly synthesized rcDNA, that relaxed DNA in the nucleus. All right, next. The other thing you need to remember is in relation to its half-life, all right? How long it can remain. Why is it causing a major issue? Well, it has a half-life of 40 days, more than a month. And it has the ability to persist for the lifespan of the cell that's inside. Now, it doesn't need a lot. A low copy number, you're talking about 1.5 copies per cell, is enough to maintain a chronic infection. All right. A reactivation of latent cccDNA has been known to occur post-treatment. That's where you get your HBV recurrence. So, in other words, to achieve a functional cure, all right, in other words, no cccDNA, it has to be eliminated from the infected cells or at least permanently silenced, all right? Sounds very ominous. Next slide. What do we have? Our famous quantitative HBS antigen, or QHBS antigen, which in UMC we've been doing for quite a while now. There are actually 3 companies that actually provide these test kits. It's an immunoassay, all right? Abbott, Roche, and Disorin. We've got the Abbott one, all right? Now, that's available. And although this assay actually reflects cccDNA and intrahepatic DNA level, the problem is that it also measures HBS antigen that arises from integrated DNA. In other words, in terms of specificity, it loses out, right? So in other words, you cannot use it to determine whether or not there's a huge number, right? Because there's so many extra bits that you're also picking up. The other thing that's rather interesting is that genotypes, the level actually vary based on genotypes, apparently higher in genotype A. And the other thing as well is that the presence of mutants, pre-SS mutants, or even the host immune control, or both, right, can result in variation of this HBS antigen level. Next. Next, please. So, next slide, please. Okay. So, the thing to bear in mind is that high levels, right, will be seen in those who are HBe antigen positive as opposed to a negative. High levels, it's associated with progression to cirrhosis and HCC, obviously. Right? For those who are E antigen negative, however, with low quantitative HBS antigen, in other words, anything less than 1,000, and low HBV DNA, which is anything less than 2,000, inactive chronic hepatitis B is suggested. The possibility of spontaneous HBS antigens clearance is there. All right. Now, if you have a test kit that's able to detect level that is even up to 100, in other words, if you have a QHBS antigen of less than 100, that actually allows you to speculate that, you know, it kind of confirms, all right, you have got inactive chronic hepatitis B. All right. But at the same time, when you have that much lower level, it actually reduces sensitivity to 35%. So there is a catch-22 with regards to that. Now, I have basically not provide slides with regards to what happens when you use pegylated interferon, but just enough, because remember, we're talking about diagnostics. So again, the AASLD basically provide very good details about that. But just to say that it is useful. It's useful in managing patients receiving pegylated interferon therapy. All right. So details about it is in the article. However, most important thing is not recommended for routine testing or follow-up of patients with chronic hepatitis B. All right. So in other words, if you want to start patient interferon therapy, great. But however, I know that even UMC, I'm using fairly routinely as part of management. All right. For be it for me to to say no, you cannot do that. All right. But ASLD basically say you're planning on starting on interferon therapy, great. It's great. In fact, when I read it, it's really helpful. It actually, this quantitative HBS antigen actually provides you some a much clearer picture about how the patient responding to pegylated interferon. Pretty good. Next slide. So those two we have available. Now, this next two is something which we may want to consider, all right? But bearing in mind, what does AASLD say? Now, With regards to HBV genotypes, we've got 10 genotypes at the moment. All right. Of course, with ASLD, of course, we talk about USA lah. I've got whereby most of it actually A to C. Is it peculiar for USA? No, actually, in this part of the world, we have also quite a lot of B, right? But they vary geographically. And the most important is that genotypes actually play a role, right, in progression of the liver disease, and also, ironically, response to interferon therapy, right? They found that those who have got genotype A, as opposed to those from B to D, actually have got higher rates of E antigen and HBs antigen loss with interferon therapy, which is rather interesting. Next slide. In Asia, of course, this paper talked about Asia and Africa, so I didn't mention anything about Africa lah. But in Asia, like I said, we tend to see a lot more B and C. So they found that, all right, when you compare it with C, B, all right, B is associated with E antigen seroconversion at an early age. B is provide a more sustained remission after E antigen seroconversion, less active hepatic necroinflammation, slower rate of progression to cirrhosis, and lower rate of hepatocellular carcinoma development. All right. Like I said, this part of the world, mainly B and C's. Right. So what is the AASLD guidance? Basically, they say that those with genotype A and B definitely are associated with higher rates of HBe antigen and or HBs antigen loss than C and D. All right. So it's a useful information. Great, useful for those who are started on pegylated interferon. However, not recommended for routine testing or follow-up patients with chronic hepatitis B. Right. So be well aware, all right? Because in Asia, we've got the B and C. Now, the other one is, of course, hepatitis B genotypes. I mean, in terms of what happened there, resist testing, all right? Now, this is something that we may want to begin considering because we have been putting patients on treatment for quite a long while. Of course, while we may not want to worry about it for those who are treatment naive, the one thing to remember is that it's first manifested as a virological breakthrough. All right. In other words, you're talking about 1 log or 10-fold increase in serum HBV DNA from 0 during treatment who had initial response. All right. So in other words, initial response, then the so-called breakthrough actually is due to resistance. And this is where you have problems with mutants because most mutants have got decreased replication fitness compared to wild type hepatitis B. All right. So the one thing that's rather interesting is that during continued treatment, all right, what we call compensatory mutations, because when mutations occur, the mutations that occur sometimes reaching to a point that what may have been terrible actually becomes good. In other words, what we're saying that during continued treatment, mutations restoring replication fitness actually has been known to emerge. Right? So mutation initially have got decreased replication fitness, right, compared to the wild type. But as you continue treatment, it actually restore its replication fitness, which in a way is not good. In other words, you're going to get progressive increase in serum HBV DNA, all right, sometimes to the point of even exceeding pre-treatment levels, all right. You need to understand, we are dealing with a DNA virus that is very good at surviving. So here you're thinking of, okay, patient's doing well, continue with treatment. The ironic thing is that the mutants, all right, well, let's put it, the reason why this is happening is that because our body have got both the wild type and the mutants, okay? So the treatment you're giving is basically killing off all the wild type. So you have the mutants who are keeping quiet and trying to survive, all right? Survive. But in a while, it's been changing, right? Maybe slowly, but changing to such a point that they may reach a point whereby our body no longer have the wild type. Now we have the resilient, right? The restored mutants that now have been able to multiply in big enough numbers to cause problems that's even worse than what we had before. All right. That's the issue of resistance, all right, especially for a DNA virus. Next slide. And what tests are available? Rather labor-intensive tests, which is, restriction fragment length polymorphism analysis, which is rather old. Hybridization technique is also old. Of course, now sequencing, lots and lots of sequencing is done. All right. But in order to be able to do any kind of sequencing work, the HBV DNA has to be more than 1,000 IU/ml. Then you can do all the sequencing work. But whatever it is, it's something that's been suggested. But as far as I know, it's not really been widely used, so to speak. But the most important thing is that ASLD basically say that, yeah, it may be useful in those who have past treatment experiences. In other words, in relation for those who have been treated and then now there's reactivation, all right? Or despite being on treatment, the viremia persists. And of course, those who experience what we call virological breakthrough during treatment itself, all right? In other words, they were initially doing very well, then poof, the level goes up for no reason whatsoever, right? So that's when you want to consider, all right, testing for viral resistance. And that's it, I think, as far as Hep B is concerned. Next slide. Oh, the last slide. This is to do with reactivation and hepatitis flare. All right, just that based. All right, I'm not going to detail about what happens, clinical presentation, all that. But when you say somebody has got reactivation, all right, criteria for reactivation would be a rise in the HBV DNA compared to baseline or absolute level of HBV DNA when the baseline is unavailable, plus reverse seroconversion from HBs antigen negative to HBs antigen positive for somebody who was previously HBs antigen negative and anti-HBC positive. All right, that's when you get reactivation. In other words, now you have a patient who is HBs antigen negative and anti-HBC positive. Suddenly, the patient became HBs antigen positive. And then when you do the HBV DNA, what was previously not detectable, there's an increase. All right, so that's when you know there is hepatitis B reactivation. What about the flare? The flare is more to do with the ALT, right? In other words, talking about a 3 times increase in level of ALT from baseline. All right. Well, talk about anything that's over 100 IU/ml. All right. So the flare is more to do with ALT, not so much in terms of the DNA. The DNA and all that is more to do with reactivation, and that's it for B. So next. So I hope you stay with me to do Hep C. All right. Now, with hepatitis C testing, next slide. I need to update you with regards to the infection itself. All right. From the very beginning, I used to tell everyone, right, don't worry about acute because and it has been confirmed. Actually, while it can cause acute and chronic, it's acute is rather uncommon. All right. And what's rather interesting is that recently acquired Hep C tends to be asymptomatic. All right. And rarely lead to symptomatic acute hepatitis A. That's why hepatitis C. So that's why you don't see acute hepatitis C. All right. Not because it's not there, but people don't notice it. And more often than not, they tend to be asymptomatic. All right. Now, for this group of patients, it has not changed over the years, but the percentage have changed. In other words, those who have been recently acquired, you have about 15 to 45% actually clear the virus spontaneously without any treatment within a span of 6 months. All right. In fact, the median time clearance is about 16.5 weeks. The remaining group, ranging from 55 to 85%, they are the ones who go on to develop hepatitis C. Even early days yet, we talked about the famous 30-70%, all right, difference between those who are acute and those who are chronically infected. Next. The next slide is the one that's rather interesting because here it relates to genotype because they found that spontaneous clearance tends to occur more often in women, those who've got genotype 1, and of course those with acute hepatitis. Less likely, ironically, to occur in those with HIV. I don't know. All right. But obviously, spontaneous clearance of course, immunosuppressed, you know. But the one important thing is this, all right? Until now, we have yet to detect or determine or even test, or don't know where it is, how to look for protective antibody. So we know that those who actually clear the infection spontaneously or through treatment, they are not immune to the virus. In other words, they are at ongoing risk and exposure to get reinfected. That's the issue. That's what WHO is addressing currently with a lot of strategies that they're doing. All right, the picking up of those who supposedly have cleared the infection. All right, but now the numbers are not decreasing. Why? Because they're continually at risk and therefore are getting reinfected. So detecting those infections and even reinfection is vital. All right, because vital in terms of treatment as prevention approach, obviously, because Hep C, no vaccine. So the only way to reduce transmission is to treat them as early as possible. That's the only way. All right, that's how we can reduce transmission, and that's how we can reduce the population prevalence, and that's how we can reduce disease-related morbidity and mortality. All right, detect those new ones and those who are reinfected as early as possible. Right? The famous treatment as prevention approach. Next slide. So this is the latest summary algorithm. All right, an overall view. Right. In other words, again, this is the latest WHO 2023's summary. All right. Of course, you do the anti-HBs antibody. Can choose either the rapid test or the lab-based immunoassay. If it's negative, end of story. If it's positive, that's where you do the viral load testing. Now, the viral load testing, this is 2023. So in other words, this is all the guidelines that have come up since 2016. Right? So this is the latest recommendation. Whether or not we want to follow, it's up to us. But we definitely, as far as viral testing, we are doing the lab-based HCV RNA, qualitative testing. All right. But the other one that they have suggested, all right, is the core antigen assay. The new one, of course, is the point of care. All right, HCV RNA assay. Okay, that's the new one. Okay, so it can be any of these. And I'll explain later about why they highlight the importance of point of care. Again, it is one of the strategies, all right, to basically, hopefully, eliminate, reduce, all right, reduce the public health problem by 2030. Now, if it's positive, obviously, there's evidence of viral infection, so you offer such treatment. If it's negative, then obviously, no need lah. All right, next. Next slide. Okay, so this is what I'm talking about. Way back in 2017, the use of RNA testing to detect presence of HCV viral infection are two. One is the lab-based HCV NAT assay, all right? In other words, basically you're talking about quantitative HCV RT-PCR, all right? Strong recommendation, moderate to low certainty of evidence. But you can, an alternative, of course, is to detect HCV core antigen. The antigen is actually protein P22, all right? Because why? It has comparable sensitivity. Okay, so in terms of recommendation, back then it's still conditional recommendation, but definitely moderate certainty of evidence. And what's new, next slide, please, is this point of care testing. Point of care HCV RNA assay, right? So this one can be used as an alternative to our lab-based HCV RNA NAT assay. Okay, because here in 2022, even in 2022, the recommendation is still conditional. In other words, because it depends on whether it's available or not, and even the certainty of evidence is still low to moderate. Okay, now why this POC? Next, why this point of care? For one thing, it's comparative with the lab-based standard. In other words, it has a sensitivity of 99%, specificity of 90%, and its limit of detection is just similar as well. So the beautiful thing is that the lab-based assay, all right, lab-based PCR, it does take a while, 2 to 3 hours. But the POC, which ironically we also have it but we use it in our lab, it takes only about an hour and easy to use, right? And definitely suitable for low numbers. And of course, in terms of user friendly, greater uptake, fast viral load testing. And because you get the result within an hour, of course, it enables the clinician to initiate testing as soon as possible, right? A shorter TAT. Next. So that's why WHO suggested that it'd be great if it can be used in low-level health facilities. It can be used for diagnosis as well as a test of cure. In fact, 2 studies have found that it's very cost-effective compared to lab-based assay, which is why way back then, very early on already, WHO has pre-qualified one POC HCV RNA assay, which is the expert, all right, expert HCV viral load. Next slide. And what is this? Just a quick, I'm not advertising them, but just to let you know what is this expert HCV viral load assay. Next slide. All right. For one thing, rapid quantitation, utilizing automated RT-PCR. They're using fluorescence, all right, to detect and quantify the HCV RNA in both serum and blood. It can quantify genotype 1 to 6, all right. The beautiful thing is that its level of detection, all right, its limit of detection is, it's wide ranging, all right. But whatever it is, its limit of detection is 10 IU per mil, which is great, all right. And of course, it allows you to convert it to log. Okay, next. Next slide. Now, the other one that's rather interesting, all right. Now, the thing I need to remind you, remember the good old days when you always do any kind of testing, EIA, we also repeatedly reactive, all right. We always do a repeat test from the same from the same sample. All right. Of course, the reason back then is more to do with the fact that we want to make sure that that result came from the correct patient. Because that's why we do a repeat testing to make sure that it is from that particular patient and not that there was some kind of lab error. That's why we do repeat testing. But ironically, this 2022 recommendation talk about what we call one-time sample collection, all right? What they call reflex HCV RNA testing. So this is only done, all right, for those who are tested anti-HCV positive, all right? Don't do it anywhere else. This is more to do with compliance, because these are the ones where if the person is Hep C positive, the last thing is for them to want to come back again, take blood again, test by PCR. All right. So we're talking about providing great compliance, enabling a prompt linkage to care and treatment. All right. So you can do it 2 ways. You can either do a reflex-based RNA testing, right? That's where you use your regular in the lab, right? Regular PCR. Or if it's in the clinic, there's clinic-based reflex test collection. All right. In other words, you collect the sample at the clinic, and then it's either sent to the lab or you can do an immediate testing via RDT, rapid rapid testing. All right. Clinic is where you do a rapid rapid testing, RDT, to detect the presence of Hep C. If the person is Hep C positive, you need to collect enough sample. I mean, the sample for that test, that sample, all right, can be sent to the facility. All right. Again, this is fairly new, so recommendation is conditional, and the quality of evidence is still pretty low. Next. Although I must say that I read 2 successes, one in Canada and the other one, where was it? Somewhere in Asia. I don't remember. Somewhere in Asia. All right. But Canada one found it was very cost effective doing this reflex testing. And these are just basically definitions. I'm not going to go, we can skip this slide, but just to say it's to do with, a subsequent test on the same sample when the sample is anti-HCV antibody positive. Next slide. So it can either be lab-based or clinic-based. Next slide. This is what I want to talk about, the benefits, all right? Because it actually simplifies care pathway, reduce the need for additional visits and time, all right, to do the viral load testing before you start them on treatment. And the thing I love most, because I'm one of them, all right, avoid the need for additional venipuncture. For those with compromised veins for blood sampling, people have crazy time trying to collect blood from me, right? So one time enough blood, single sampling, that'd be great. But the most important advantage, all right, of reflex testing is that obviously cost saving, obviously improve compliance, but easy to implement. But the most important thing is that it has potential for widespread adoption, even in settings where it is resource limited. And what's important is that, because remember, WHO's strategy is to make sure that not just that the testing is available, but the treatment itself is also available as soon as possible. So doing this helps promote testing and treatment uptake to extremely advantageous level. All right, next slide. And that's why, with regards to assessment of treatment response, now the other thing I need to remind you is that we have been using the lab-based entity testing. All right, this is 2017 punya recommendation that we use the nucleic acid testing. All right, to determine response to treatment. All right, in other words, to document cure at 12 or 24 weeks. Right, after completion of antiviral treatment. The 22 one talks about the use of POC, point of care HCV RNA, right? Because it's the same thing, comparable limit of detection, all right? So it can be used as an alternative. And as you can see, in terms of conditional recommendation, recommendation evidence is still the same, right? This is 2022 punya recommendation that you can also use the POC HCV RNA assay. Next. Now, what's interesting is this. The American Association for Study of Liver Disease, the American thing, right? Basically, based on that, all right, they updated their guidelines, all right, and suggested this, right? One, to include reflex HCV RNA PCR for initial Hep C testing if they are anti-HCV positive. And among those who are negative but exposed to HCV within the last 6 months, test for HCV RNA or anti-HCV 6 months or longer after exposure. And if the person is immunosuppressed, of course, to HCV RNA. And for those at risk of reinfection, right, after they have cleared, in other words, whether it's because of spontaneous clearance or because of the treatment, then use HCV RNA. Because obviously this patient will be anti-HCV positive. So for God's sake, don't use that test. Do HCV RNA test. All right, next slide. Now, in terms of initial testing and follow-up, this suggests quantitative HCV RNA prior to initiation of treatment because you want to document the baseline. All right. Now, as far as genotyping is concerned, which we do, all right, may be considered for those in whom it may alter treatment recommendations because we know that certain genotypes, they do respond better, all right, on interferon therapy. But with the direct acting, not really, all right? Especially now we're doing pan-genotypic, all right? But whatever it is, for those who are anti-HCV positive, all right, and HCV RNA negative, well, we tell them that, okay, you've got no active infection, but you must remind them just because you are anti-HCV positive and you are HCV RNA negative, it doesn't mean you are protected, right? In other words, you can get reinfected, all right? So in other words, you need to be careful with your evidence of any kind of risk exposure. So you need to be advised on that. So last year, the American Association for Study of Liver Disease strongly advise that. Next slide. Now, what's rather interesting is what WHO did in 2023. All right, they for Hep C. All right, this is pertaining to Hep C because they also have received a lot of feedback with regard to the problems of reactivation. Those have cleared. Can they now go away? Are they okay now? Do they need any kind of follow-up? Well, the 2023 WHO recommendation said that they need to do HCV retesting for presence of viremia after having resolved. In other words, they're saying that people at ongoing risk and history of treatment-induced or spontaneous clearance Hep C may be offered, all right? 3 to 6 monthly testing, okay, for presence of HCV viremia. Now, recommendations is conditional, very low evidence, all right? Now, why did they say that? Well, for one thing, they say that testing shouldn't be mandatory, all right? They say that, yeah, it's available. They said it may be offered. So in other words, you're talking about something that's voluntary. So we shouldn't push them because at the end of the day, Hep C is a stigma, all right? So, especially those at ongoing risk. But the one thing we need to tell them is that it does reduce transmission, all right? And the availability of the testing is positive straight away, we can start you on treatment, all right? So that's the advice we give them. And what do we use? Of course, we use HCV RNA, or alternatively, HCV core antigen. Next slide. The other recommendation is to use a pan-genotypic direct-acting antiviral agents, all right? They are the ones who finally, because of all the testing that's been done, now there are enough, all right, DDA drugs around that are pan-genotypic, so they are now suggesting they should be offered without delay, especially those who have recently acquired the infection are at ongoing risk, right? Here, the recommendation is strong, even though the evidence is very low. Certainty of evidence is low, but it's a strong recommendation. Why? Because they say that individuals with recently acquired infection, they must have the option, all right, to make an informed choice about starting treatment immediately or delaying treatment initiation. So we leave it to them. And that treatment for recently acquired, all right, they want it to be offered alongside with any additional intervention, all right, or primary prevention services that's available. So don't just treat them, but also provide some kind of educational advice, right? Especially when you know what is their risk history, right? So these are the two new ones. So why did WHO make that push? Right, next slide. Why this new recommendation this year? Right. The reasons for the update, next slide, is because of this, right? The Global Health Initiative, all right, initiated by WHO, basically talked about wanting to eliminate not just Hep B and Hep C, but I just talk about Hep B and Hep C because of course there's HIV and all the STDs and all that. But by 2030, all right, we are now in 2023, not very far ahead. So I'll just highlight two initiatives that related to testing. In that, there should be substantial increase in access to Hep B, Hep C testing to reach people living with chronic Hep B and Hep C, for whom this is 2012, all right? 2020, okay? That more than 80% of Hep B and 90% of Hep C are currently undiagnosed, all right? So that's what they said. And the other one is that to promote simplified service delivery models that include decentralizing Hep B and Hep C testing and treatment to low-level health facilities. That's where the POCT come in, point of care testing available. Okay, so what is this that we want to eliminate? Just a couple of slides on what the target is. Next slide. So, all right, very ambitious, right? 2020 in terms of level up to 0.1 only. Number of new cases from 20%, 20 per 100,000 to only 2 per 100,000, right? Dying from 10 per 100,000 to only 4 per 100,000. But what's important is this, the last one, percentage of people living with Hep B diagnosed and treated. Now in 2020, living with Hep diagnosed only 30% and treated only 30%. What they hope to be able to do with all this new thing is to increase it to 90%. Hopefully, they want 90% to be diagnosed and 80% to be treated. And the only way for that is for the two to merge together. All right. And this is for Hep B. All right. We have the vaccine. That's helped a lot for number one. All right. In terms of treatment and diagnosis, this is what we hope to achieve with all these new tests. Hep C, next. For Hep C, all right, again, from 20 per 100,000 to 5 per 100,000 for new infections, all right? Number of new Hep C infection This is to do with illicit drug users from 8 per 100 to 2 per 100. And then again, importance of percentage of people living with Hep C diagnosed and cured. Of course, here with Hep C, we're talking about cure, all right? So the percentage they hope to achieve is similar to that with Hep B in that diagnosis from 30, hoping to reach to 90%, and from 30, hoping to reach 80% in terms of cure. And bearing in mind that in terms of cure here, talking about also helping to reduce reinfection. Because remember, treatment of those who are initially exposed and those who are reinfection, if they're cured, you're indirectly reducing the prevalence, reducing the rate, reducing transmission. And next slide. So what is our achievement? Next slide. Last one. This is what we have done so far. All right. Of course, we're still progressing. In terms of tests, of course, for Hep B, with some HBV PCR quantification, that's everywhere. All right. Now, quantitative HBs antigen immunoassay, it's available, but be careful how you use it. All right. I've seen it being abused, not misused, but abused. They're doing it for everything. All right. And then after they're promised trying to interpret the results. All right. With Hep C, of course, we've got the quality and quantitative PCR, no problem whatsoever. No point of care testing. Now in Malaysia, we have got the expert. All right, we've got that POC machine. Now the issue is that do we want to make it available for Hep C as well? All right, that's the plan. And of course, Hep C genotyping, not really an issue anymore. Early days, yes, but no, because now we've got pan-genotypic DNA, so not an issue. But core antigen, it's available. How well do you want to use it? It's up to us, all right? Because it's still fairly expensive. Now, in terms of clinical practice guidelines, we do have that. In fact, in 2019, we have got that for management of chronic hepatitis C. And then, sorry for the typo, it's not 2022 because 2022 for Hep B, we started it. We finished in 2022. Hopefully, it should be made available with all that, the MOHPP pack and all kind of stuff like that more available this year. All right. So it's in its final stages. So we do have the guidelines, all right. But you need to bear in mind, for those of us who are diagnostician, these two guidelines are not really helpful, all right, because it's more to do with management. They do mention a little bit about diagnostics, but it's more to do with all the different drugs that's available. Okay, so whatever it is, the American Association for the Cell Liver Disease, the AASLD, their guidelines includes very lab-related advice, which is pretty good. Like I said, it's been cited in more than 3,000 articles. So they can do no wrong, right? Over 3,000. And with that, next slide is just reference. I thank you very much. Thank you for your patience. Like I said, I will try and answer any of the questions that have appeared in the chat.
Thank you, Prof, for the insightful talk in the latest updates on the HBV and HCV testing and its challenges. Now I open the floor for Q&A session. Dear participant, you may type your question in the chat box. Alternatively, you may also raise your hand by clicking on the icon. We will send you a request to unmute you if you wish to ask question to the speaker directly. So there's already one question, Prof, in the chat box. The question is, if the first Hep B surface antigen is positive, but the second Hep B surface antigen taken 3 months from the first sample is negative, with negative Hep BE antigen and Hep BE antibody and also anti-HBC total is also negative, is it safe to say the first Hep B surface antigen sample is false positive?
Absolutely 100% correct. And it's been known to happen because the thing is that our immunoassays nowadays, because in its effort to be able to want to pick up as many positives as possible, you get now it's insignificant, but there's still a level of false positivity. All right, and that's why, as far as hepatitis B testing is concerned, do not, I repeat, do not be dependent on one marker always have, you've got all those different seromarkers, use them. Do not, I know sometimes we've got so many difficult for us to interpret, but they help you. In other words, if you need me, I can help you. All right. One marker is not enough. Now you need to bear in mind, CDC, all right, early days, we were just using HBS antigen. And then we tambah anti-HBS. And now CDC say include anti-HBC total. So we are increasing because the thing you need to bear in mind is that in its effort, all right, to be able to diagnose hepatitis B at a very early stage, the test kits now have become much more specific, all right? In other words, the incidence, the percentage of false positivity is low, but it is not negligible, all right? So that's why we need monitoring, we need follow-up, especially in those who have history of high-risk behavior. All right. Any other question?
Okay, Prof. So this is from the same question. Do you need further testing for
No.
result?
No. But but before you do say for the testing, all right, the fact that this person is everything negative, vaccinate the fellow lah. All right, vaccinate the person. All right, then no problem. A vaccine is available. Vaccinate the fellow.
All right. Okay, thank you, Prof. Any more question? From the chat box. Okay. There's one more question. With regards to screening with anti-HBC, with regard to screening with anti-HBC found to be positive in vaccine non-responder population, do they still require vaccine administration?
Well, okay. Now this one requires a little bit of detail. First of all right, that means they have been given the 3 doses, they didn't respond, all right? But the problem, which basically means that they are susceptible to the infection. And now they're found to be anti-HBC core positive, which means that they have, the vaccine didn't help, and now they've been exposed to hepatitis B. So this is the one whereby you need to find out whether they are also HBs antigen positive. If they only have anti-HBC positivity, all right, and there's no evidence of any history of any risk behavior, we leave it at that. All right, leave it at that. In other words, if you want to follow up based on the risk behavior, fine. All right, but this person is a hepatitis B non-responder. Although, all right, there have been studies to show that some of these people, the fact that the patient has got is anti-HBC positive, indicates that, you know, it could be a false positive, but could indicate the person has actually been exposed to hepatitis B. All right, could be 2 reasons. Remember, I gave you the long sort of all the possibilities. Okay, at the same time, you know, worst case scenario, oh, mutant, HBs antigen not detected. But whatever it is, look for HBs antigen. Right? In other words, look for the especially you know, HBs anti-HBs. For all you know, all right, that's why I always tell people, don't look only for one marker. All right, always do at least the minimum 3. That in itself, based on the history, will give you an idea on how to interpret the results. All right. Okay, I hope that helps.
The next question, in your opinion, how can we improve public awareness of Hep B and Hep C?
Now,
public awareness.
The ironic thing is that I've actually been involved in 2 NGO groups, right, that have been doing exactly that. All right. They other than the Malaysian Liver Foundation, all right, there is a group called the Free Hepatitis or Hepatitis Free Malaysia. Hepatitis Free Malaysia. They have been going around, all right, not just giving talks, but also testing them. And this is done in old folks' home, in any kind of public area, all right, whereby they are tested, all right, and then those who are found, because these are all rapid tests, so those who are found to be negative are immediately vaccinated with support from drug companies. All right. So this has been ongoing. There may not have been any major public thing, but these two groups, all right, have been doing it for more than 20 years. All right. So the public is well aware. They know about Hep B. Hep C, not quite, but Hep B, definitely. All right. Because of the availability of the vaccine and because of support from the pharmaceutical industries and also the diagnostic companies. All right. So that has been ongoing. Okay. With Malaysian Foundation, they've been doing that since what? Late 1990s? More than 20 years. All right. With Hepatitis Free Malaysia, I think at least 10 years, if not more. Right? So they've been doing that. But of course, things have quietened down a bit because of COVID, but I'm very, very sure they'll start it up again. All right. So that one, rest assured, there are NGOs who are going about it.
Okay, Prof. Thank you. The next question is it necessary to do anti-HBs even though the Hep B surface antigen is already reactive?
The sad thing or the ironic thing is that we have now test kits that are so sensitive, they'll pick up both. All right. In other words, there'll be a point in time whereby the HBs antigen is about to come down, all right, and the anti-HBs is about to go up. These are the patients whereby they need a follow-up testing, whereby hopefully you see the HBs antigen disappearing and anti-HBs appearing. I've had patients where it's the reverse. In other words, the anti-HBs disappeared, the HBs antigen went up. All right. So, like I said, as far as hepatitis B is concerned, you need monitoring. You need more than one testing. I know sometimes it can be rather confusing, but I assure you, all right, there are reasons why certain things appear, why certain things happen. And the most important thing is that the test kits we have nowadays, there is problems of false negativity, false positivity, not false negativity in the point of the kit itself, but because it detects such low level that you're able to pick it up. All right. So they need follow-up. Then you can see the full picture after that. All right.
Okay.
Yes. I
Next
had that
question.
issue way back in 1990s. Yes.
Okay. Okay, Prof. Thank you. The next question is, can you elaborate on the HBV DNA test?
Elaborate in what context?
It doesn't say.
HBV DNA, that's a PCR lah. RT-PCR, real-time PCR, quantitative PCR.
Okay, Prof. I think I can move to the next question. If a patient is HCV antibody positive, but HCV DNA is not detected, what is the accepted time frame for repeating HCV DNA?
No lah,
Annually
not HCV
or
DNA.
6 monthly?
HCV RNA. HCV is an RNA virus.
RNA, yeah, HCV
okay.
RNA, sorry.
It depends
What is the
on.
accepted time?
Okay, it depends on the person's risk behavior. All right. So I've had hepatology gastroenterologist, and again, it's in the AASLD about it being done, periodically. It ranges between 3 to 6 months, right? It also depends on the patients, where the patient is, and also it depends on how high, if the person is positive, how positive is it, or is it equivalent positive? So you decide, in other words, the pathologist will decide on how frequent between 3 to 6 months. All right. There is no cut-off date. All right. Different patients have got different needs and different requirements. So if they can, but please, no monthly or weekly stuff. No, 3-6 months. Right. The general consensus is between every 3 months or 6 months. Right. You can choose, but definitely they need follow up.
All right. Okay. Okay. I think that is the last question. So due to time constraint, we need to end this seminar. On behalf of Department of Medical Microbiology and Parasitology, UITM, we would like to thank you so much, Prof, for the wonderful and very informative talk. Thank you very much for joining. Thank you, Prof.
Welcome.